boomer generation, and I experienced it in my own family of taking care of my father with hospice and with all of these community resources that are available. And my question was, and I appreciate the answer, was, so this is not just a question of resources, because it would it not have to take a change in attitude of the VA itself to want to emerge into something that large? And I mean, if the resources were available, would the VA do that today? Would they literally say, okay, here's the need, here's 5 million people, we have the resources to match it, we're going to quadruple the program, hire the 70,000 providers? Is that something the VA would do, or is that anywhere on their priority list from the work that you've done on the question?
So you'll have to ask the VA kind of on their priority list. What we know from our research is that this one-size-fits-all approach is not necessarily going to work. So if the program right now is really geared towards this group of younger veterans who have chronic conditions that will probably persist for a long time, the program may need to be adapted in very critical ways to care for, as you said, perhaps more home health aid, kind of a group of people who may be suffering from conditions associated with aging, which may be very, very different.
Right, and I also have a question about that.
Yeah.
I have a constituent, Daryl and Lisa Stump, in my district in Indiana, and we just became involved with their case a week ago, and Mr. Stump passed away Saturday. And this was all over this issue of family advocacy, home health care, no other options. You know, the VA refused to pay virtually every option that would be on the books. VA refused. They brought him back home. The wife's been caring for him by herself, had to quit her job. They're living on disability, and she is she's become basically the caregiver, doctor, hospice worker, all in all of the above, just because of being turned down so many times. He dies. But one of the things that we have found in trying to advocate, even for constituents, is this letter of the law interpretation of HIPAA with the VA's interpretation, right? So the VA is there to provide all the direction. If they're 100% disabled, Agent Orange, which this constituent wasn't receiving probably even half the services that were available to him, just because either lack of knowledge or being turned down once by the VA and being too tired, no respite care, being turned under by taking care of their loved one. But we have so many issues with this issue of if you're not the veteran calling in for help, you can't get any medical advice, you can't get any medical services, and you're basically, the answer is, I want to talk to the veteran. If the veteran is suicidal, I still want to talk to the veteran. If the veteran is not mentally competent, I still want to talk to the veteran. When it comes to this whole issue of somebody advocating for you, say if it's your spouse or it's your neighbor or it's your cousin being the advocate, what have you found it's been like with trying to get information out of the VA to even help the person that they're supposedly helping? Do they get a clearance with the VA to be able to access all that medical information, since oftentimes the spouse doesn't even know their name's on file?
So the VA was probably better poised to answer that when they assign somebody a primary caregiver, what records that actually permits them to have access to. But in our recommendation, in our research, we heard the same complaint that you're raising a lot, and we did make a recommendation to make healthcare environments more caregiver-friendly. This means really educating physicians and other healthcare providers about really kind of what HIPAA allows and doesn't allow to better care for their caregivers, because we know that talking to the caregivers to ensure that whatever is being prescribed for caring for that veteran can be adhered to, because oftentimes it requires the caregiver to actually follow through with the adherence.
Right. And my concern for this pre-9/11 group is that oftentimes, especially if you're looking now at Agent Orange, you're looking at senior citizens. You're looking at seniors going from the baby boomer generation with a lot of the same kind of chronic conditions, same kind of chronic symptoms, dying of the same types of conditions because of Agent Orange. And it seems that, back to your point, if they could, if you could almost put groups together that says, this is the kind of care these folks are going to need, because quite often they have the same kind of symptoms. They have lung cancer, they have COPD, they have things that become so prohibitive, and so they need a lot of the same kind of care. They need oxygen, they need, regular interaction with doctors. And I guess my final question is, when it comes to this issue like rural health and rural telehealth and the things that the VA is doing fairly well within rural areas, is that something that you see as a benefit? Does that kind of roll into this whole thing of family members becoming advocates and trying to help keep them out of long-term facilities?
In our research, we actually didn't, I mean, we couldn't longitudinally look and see who was in a long-term facility and who wasn't. We really didn't see much difference between caregivers who live in rural areas and those who live in metropolitan areas. Nor were we really able to evaluate whether the organizations currently serving caregivers are more prevalent in kind of rural areas or metropolitan areas.
I appreciate it. I appreciate your research. I yield back, Mr. Chairman.